total joints. So hopefully there's at least some food for thought in here. You know, treating total joints isn't rocket science, but we all can learn a little bit, I think, about how to prescribe exercise to these patients. And my hope with this conversation is that there's information in here that we can expand to all of our patient populations, kind of how to manage patients when challenges come up and what we should do in those situations. So total joint, particularly total knee for this talk, is going to be kind of the foundation, but or like the how we're having the conversation, but it can certainly apply to other patients. Would this remote be able to advance the slide? So throughout this talk, I came up with some patient examples. So we'll talk about the patient case and what challenges we might be facing, and then how we would advance care based on what we're finding with this particular patient. Okay. So hopefully by the end of this conversation, we'll have a better understanding of the why and the when around exercise prescription after total joint replacement. Be able to apply exercise prescription principles to the cases that we discussed, and again, extrapolate that to other patients, and explore potential post-op pitfalls and how to help patients manage them as they come up. One other thing I wanted to mention is, you know, the nice thing about treating total joint replacement is that we don't have the same restrictions that we might have with like ACL or meniscus repair, because we don't have the same tissue healing that we have to sort of pay attention to. And so generally patients can kind of progress as they can tolerate it. And as we assess them and determine that they're ready to move forward, we don't have to worry that the exercise that we're prescribing might stress whatever tissue too much, or be concerned that the exercise is putting tension on a particular ligament. So total joint rehab is very much about assessing impairments and then moving patients forward. Okay, so a little bit of background. At OHSU, when patients have a total knee replacement, they spend sometimes 0 nights in the hospital, up to 2 nights, unless something really complicated happens. But on average, most patients stay 1 night. And we see patients from a very wide background. So majority of patients are sort of your typical primary osteoarthritis patients, age 50 to 70. But we do see some patients who are young with OA, either from trauma that they maybe have incurred and had multiple other surgeries and ultimately end up needing a total knee replacement, or who might have some type of like other disease process, whether that's like inflammatory arthritis or hemophilia or something that has damaged their joint earlier than you might see in the normal population and need a total knee. And so some of our 50 to 70-year-old patients are trying to get back to really high level activity, and many of the younger patients are hoping to restore at least some of the function that they had before they were injured or their disease process took over. So we're often helping patients get back to things like running and jumping and sporting activities. And then total hip patients, pretty similar. They're also spending 0 to 2 nights in the hospital with an average of 1 night. These folks do tend to be the older population, occasionally someone younger or a history of some kind of trauma. And then again, ranges of activity level. Some patients who just need to be able to ambulate around their home, and other patients who want to get back to skiing and tennis and things like that. Our surgeons do a variety of anterior and posterior approaches. So we're managing patients, some with precautions and some who don't have precautions. Somewhat recently, our orthopedic surgeons started referring patients for more prehab. Previously, we had been doing preoperative appointments 1 to 2 weeks prior to a total knee or a total hip. And we've now started this prehab pathway where ideally patients are coming to us to physical therapy at 6 to 12 weeks prior to surgery so that we can assess where they're at. We assess their range of motion, their strength, we do functional tests at that time, figure out what the patient's goals are, and then we start providing education about what the surgery is going to be like and how to recover from it, and then, or what to expect while recovering from it, and then really get them on a good range of motion and strength program. We know that immediately after surgery, there's a lot of atrophy that occurs just with that short time of immobilization and high level of pain. And so if we can set people up with a strengthening program prior to surgery and gain some strength, then we know that we'll have better outcomes afterward. So we're really trying to push this program forward. And one of our therapists worked hard on creating a protocol for this program, which we shared with the cohort while they were here. And I know that your systems are a little bit different than ours, but getting patients started on some type of program similar to this would be a great benefit and help their rehab afterward. And then the functional tests that we tend to do for this population of patients is the timed up and go, the 30-second sit to stand, 10-meter walk test for speed, single in a stance, and then a 6-minute walk test. And so typically we would be assessing those ideally like when the patient first comes to us for prehab, so maybe 6 to 12 weeks before surgery. And then if we have an opportunity, then we would do it again prior to surgery and see what change they've been able to make over that first period of time. And then we would do them again at immediately post-operative once they come back to us for physical therapy, which is usually somewhere around 4 to 10 days post-operatively for the total knees. And then we'd test them periodically throughout their recovery process to see how they're progressing, compare them to themselves prior to surgery and just after surgery, compare them to the normative values that we have for their age and their gender. And then if there are areas that they're not passing the test and we would expect them to be, then we would prescribe exercise based on that. And we'll talk a little bit more about that as we go along. That's summarized on this slide here. The other part of the prehab pathway is to teach the basic postoperative exercises that we would expect patients to start doing once they're discharged from the hospital. They do those exercises for a few days at home before they start coming to outpatient therapy. So the way I kind of think about rehab for patients is in categories. So it sort of broke things down by total knee and total hip. What are the categories of areas where we have to help patients progress? So for both total knee and total hip, we need to help them with range of motion. Specifically for total knee, quad strengthening is going to be huge for everybody. Hip and core strengthening for both groups, gait training, balance, functional strengthening, and then getting them back to the activities that they want to do. And so as we go along, we'll kind of talk about things in those categories as impairments that you might find with the patients that you'll have to help them through their rehab process to make sure that you're creating a well-balanced program for them to ultimately get back to the activities that they're interested in and progressing back to. Okay, so focusing primarily on total knee replacement here. So range of motion is initially the most important thing that we work on, and how quickly patients get their range of motion back may then dictate how quickly they're going back to other things and what other exercises that we can start. So we know there's a need for early range of motion. The goal for us is to be at about 90 to 100 degrees by the end of week 2 and 110 degrees by week 4. And so we're working with patients to work back to that, trying to find the right exercises for them that aren't too painful, but are progressing their range of motion forward. If patients aren't meeting that range of motion requirement of 100 degrees by week 2 or around 90 degrees, then we would get back to the surgeon and let them know that we're not seeing progress. I think this is where our systems kind of differ. Our surgeons aren't following up with the patients as regularly as they are in your system. And so it's up to the physical therapist to give information back to our surgeons when patients aren't progressing at the rate that we would expect them to. So we're communicating with the surgeon if we're noticing that patients aren't quite getting back to the range of motion that we would expect them to. Of course, some of it depends on what their range of motion was like prior to surgery. If they didn't have great range before, then we probably don't expect them to have, much better range of motion after surgery than they had prior to surgery. And that's another reason why that prehab process is so important. If we can gain a little bit more range back before surgery, then we know that we're going to do better with that after surgery. So I just put this on here, like thinking about what are the reasons that their range of motion may not be coming back. So types of stretches, joint mobility, if their hip is flexed and their knee is flexed. Like in this first picture here, if our patient can't bend their knee very well in that place, then likely you're dealing with some joint stiffness, maybe muscle guarding. And in that situation, then soft tissue mobilization, joint mobilization, working on the stiffness of the joint can be helpful. If they're also stiff with their knee extended, their hip extended here, then quad lengthening should probably be part of their recovery process. And I find that a lot of patients do well with this type of stretching, especially if they're having a lot of pain, because we kind of take the joint stiffness piece out of it if we can, and mobilize the soft tissue, which generally is tolerated better. But I think a lot of patients don't end up stretching with their hip in extension, and that is an area of opportunity. Not everybody can tolerate being prone, but if they can get a lot out of gaining range of motion in those positions. So other opportunities for flexion range of motion, seated, supine. I like this one, putting people up on the step and getting them to flex over the knee. Getting on the bike is a great opportunity as well. Especially for our patients who have access to a gym or a little pedaler bike at home, we try to get them on this as quickly as we can. Okay, and then extension. We all know extension is maybe more important than flexion, especially in those early phases. So what's the limitation? Muscle guarding or joint stiffness? And how do you decide, again, like what the right exercise is for each patient? We start all of our total knees with a leg prop, typically in supine because it tends to be more comfortable. But if patients can't tolerate it, then we might have them sit up and try it, like this man here. Sometimes we'll give people stretching, especially if a lot of it is muscle guarding or determined to be calf or hamstring tightness, then doing some of that soft tissue stretching and manual soft tissue work to try to settle the muscles down to allow them to get into extension can be incredibly helpful. So in the clinic, we might be working on, again, like working manual therapy to improve joint stiffness, and then teaching them some exercises to be doing at home as well. I personally really like the prone hang if patients can tolerate it, because you get that external force from gravity that is just not the same when they're in supine. So lots of opportunities for improving the extension. I feel like the patients who do well with extension do great with it, and the patients who don't, and the ones who don't really need our help in terms of like getting that range of motion back. Otherwise, they're set up for a poor outcome afterward. So thinking about dosage, what's the right amount? Ideally, we're giving people low, long duration stretches of 5 to 10 minutes at a time if they can tolerate that. But pain level, compliance, and how far out from surgery they are might have you change how you recommend patients do this type of stretching at home, especially the patients. Sorry, I keep pushing the wrong button. Especially the patients who have this high pain level, sometimes they have to back off of the exercise for a day or 2 or 3 or longer to allow them to better tolerate doing the exercise. So it's a very you have to fine tune the exercise program based on the moment for these patients. And then I think following up with some type of muscle activation exercise after stretching is really important. And so doing quad sets or open chain knee extension immediately after stretching to teach the muscle how to function in the new range of motion that you ideally have gained is important. So utilizing NMES that we'll talk about later, utilizing some of those opportunities for activating the muscles in that new range of motion. Okay, so patient example, this patient is 2 weeks post-op, their pain is an 8 out of 10, so fairly high, and they're struggling to do their exercise routine at home. Their range of motion right now is lacking 10 degrees of extension, and they can bend to 75 degrees. And when they stretch, they complain of pain at the back of the thigh and the front of the knee when they do extension, and flexion is just global knee pain. So in this situation, what should we do for this patient? Right now, they're doing heel slides using a strap like this and bending, and they're saying it just hurts the knee. They're doing this heel prop. They're supposed to do it for 5 minutes, 3 times a day, but they can only tolerate doing it for about a minute. And so sometimes they just choose not to do it. And then they're doing these seated heel slide as well. And so for this patient, in this situation, I would probably suggest that they stop doing things as often. Still do some exercise, but for maybe a day or two, let's try to rest the knee, ice it more often. In therapy, maybe do some massage, try to help them settle down so that they can have a more successful time, hopefully in a few days, to be able to stretch more. And I think sometimes in PT, it's hard to tell people to stop doing things because we just want to keep pushing them forward. But sometimes slowing things down actually is more beneficial for a brief period of time than to try to keep pushing and you're just pushing up against something that's not going to budge. So, giving a little bit of education around when to take pain medication and how to manage pain and slowing down on the exercise can be really helpful. Okay, next patient example, 4 weeks post-op, their pain's 2 to 3 out of 10, so fairly low. Right now they have full extension to 0 and 95 degrees of flexion, and their pain location is more anteriorly when they're in flexion. Right now for exercise, they're doing seated knee flexion 2 times a day, and they're sitting on their bike, but they can't get all the way around because they only have 95 degrees of knee flexion. So do we need to alert the surgeon in this situation? Maybe. They might be a little bit stiff. Our surgeons probably may want to start thinking about, in a couple of weeks, if they don't get the range of motion back, would we consider doing a manipulation? But hopefully we can keep moving this patient forward. So in terms of adjusting their home exercise program, I would think, now they've been doing 1 set of 10 of this seated knee flexion exercise. We probably could change the dosage. Let them hold that stretch longer, but not do as many of them. Maybe see if we can get them in a Thomas stretch or in a prone quad stretch if they can tolerate it, and see if we start to do longer duration holds, kind of applying those principles of tissue extensibility. Can we improve their range of motion? Testing them before they stretch, testing them after they stretch to see if we're gaining some range of motion. So that's where dosage can be really important. And maybe we don't even need to change this exercise, but we just need to tell them to hold it longer and start to push the range of motion, breathe into it, and settle into the fact that they don't have a ton of pain. So it's just a bit uncomfortable. And then maybe they can start getting around on their bike sooner. All right, so quadricep strengthening, moving along, we know is really important. So people start out with legs like this or like this, and we want them to have legs like this, right? Mm-hmm. Maybe not, but maybe a little bit more than this. So everybody after a total knee is going to need to strengthen their quads. We know that without a doubt. The question is, how quickly can we progress them? And we start slow and basic, and then we progress them as the patient is able to. The research tells us that for total knees, accelerated strengthening is okay. Patients who have been run through accelerated strengthening and progressive strengthening programs do just as well, if not better, than patients who take a slower approach to strengthening. And so we know we can kind of push our total knee patients a little bit faster, especially if we've gotten their pain fairly well under control. So opportunities here, we start with NMES, just doing quad sets. Can they turn the muscle on? Do they do a better job with neuromuscular electrical stimulations? We generally know that they do. Like Janelle talked about earlier today for our ACLs, we try to get all of our total knees to take a unit home with them. That's not possible for everybody, but ideally they're doing this at home every day, multiple times a day, working on their quadriceps activation. And then we might progress them to doing NMES with a straight leg raise. So asking them to load up that muscle a little bit more. Once they can do that well, then we move on both to open chain. Sorry, my graphic got a little funny, and closed chain. So we can do both at the same time. Whereas with ACL, we have to consider some other things. Total knees, we can move them along fairly quickly. So moving to open chain knee extension, maybe without any weight, but with the NMES on still, adding a band eventually, and or doing it on the machine once they can tolerate it. And then closed chain progression, squats, wall sits, step ups, step downs, lunges, and then eventually, for some patients, single leg squats. So advancing them through as quickly as they can tolerate it, keeping in mind, some of the tissue healing principles that we have to consider, and what their goals are. But getting patients into these positions where they're bending the knee against their body weight as quickly as they can get there. Okay, so our next patient example is 2 weeks post-op. They have pretty good range of motion, 0 to 100 degrees. They have fair quad setting, so they can kind of turn it on, but it's not great. And they can't do a straight leg raise without their knee bending. And they're still using the walker at this time to walk. Generally, we try to get most of our patients off the walker by around 2 weeks, but some of them need a little bit of assistance. So what would we recommend that they start doing now? If they hadn't been doing NMES, then we really should start it at this point. We should have probably started it sooner, but for the first 6 weeks post-op, total knees should be doing NMES, so that we can work on that muscle activation, and then work with them to try to progress them off of the walker, start to use a cane if they can tolerate it, maybe start some weight shifting so that they're getting used to using that quadricep under weight bearing load. As far as dosage goes for NMES, generally we're recommending about 20 minutes, 2 to 3 times a day, if they're not fatiguing too much. And these are the parameters that we typically use. You start with a 10-second contraction on and a 50-second relax time, and then we can reduce that time as their fatigue improves. And then amplitude, I'm sure that you all are doing this with your patients as well. It's all about teaching them what it should feel like. It's not very comfortable to do NMES. And so being okay with an amplitude that's high enough to create a contraction can sometimes be a little bit of a challenge to find. And that's why, ideally during the prehab program, we're having them try NMES. So they know what it feels like. It's not going to be a surprise to them after surgery. And when they're more painful, more sore, it's harder to do something new that you have not experienced before. Okay, so now our patient has moved forward. We're 4 weeks post-op. We've got 0 to 110 degrees range of motion. Now they can do a complete straight leg raise without a lag, and they can do a full long arc quad. They're able to ambulate without an assistive device. They've been doing their quad sets with NMES for 20 minutes, 2 times a day. They've been doing 3 sets of 15 of straight leg raises, and they've been doing 3 sets of 15 once a day of long arc quads. Seems like now, given that they can do all these things and you know where they're at, they're ready to progress. So what I would suggest doing now, if they can tolerate it, is start to do some weight bearing strengthening. Can they start doing mini squats, sit to stands, start loading their quad in a more weight bearing fashion, and potentially adding some weight to their long arm quad if they can tolerate it. They're 4 weeks post-op, so it might be worth continuing with NMES, but maybe at under load. Okay, so that same patient, we gave them squats and maybe step ups, and now they're complaining of anterior knee pains. What should we do with their home exercise program in that situation? Are there opportunities to potentially help this patient? So we could consider adjusting the depth of their squat. If they're doing a really deep squat, then maybe we go a little less deep, or have them try a wall slide instead, just to offload a little bit. Go back to open chain strengthening if we had taken that away. If they are tolerating that better, maybe we need to continue to do that. Decrease the load by putting them on a leg press or a shuttle. And then this would be a great time to start blood flow restriction if it hadn't already been used. And so doing blood flow restriction while they're doing open chain knee extension. Sometimes we'll even do blood flow restriction with the NMES on, so you got lots of things going on the leg. And maybe even doing BFR while they're on a reduced load leg press, shuttle press. Okay, so we helped them through their knee pain. And now they're 8 weeks post-op. Their range of motion is 0 to 125, so getting pretty close to what we consider normal. And their pain is 1 out of 10, sometimes up to 5 out of 10 when they're descending stairs, if they're descending with their non-surgical leg. Right now, they can complete 10 sit-to-stands in 30 seconds. They've passed the tug test within normal limits. They're doing a daily exercise routine, which includes riding their bike, stationary bike, and they can go up the stairs reciprocally, but going down is hard. So what's next up for this patient? Next, in my mind, is we start loading them more. They need to learn how to control their body weight under load. You know that standing on one leg and going down a step is painful. So teaching them to be able to control their body weight, maybe less than their body weight to start out, and start strengthening in that way. So single leg press, squats, but maybe getting them over onto that cervical leg a little bit more. Really starting them on open chain knee extension if they haven't started that yet, ideally on a machine. So our patients who have access to a gym, we encourage them to get to the gym 2 or 3 times a week to be able to start doing that. We see our patients at this point in their recovery, we would be seeing them once a week in clinic. And so once a week in clinic isn't enough strengthening. If they don't have access to a machine, then we have to figure that out, maybe using bands, or do they have weights at home, or are we really going to have to rehab with other opportunities besides open chain extension against resistance? And then starting our step ups and lunges if they can tolerate it, if their knee pain allows for it. Okay, creative ways to adjust parameters in later stages of rehab. Again, this isn't rocket science, but decreasing or increasing speed, adding holds to the strengthening exercises. So squat, hold it down, shift your weight side to side. Those parameters are easy to change, and you don't have to change the amount of weight you're using. You just ask people to work a little bit harder in a different way. And then moving through partial ranges of motion, decreasing rest time are other opportunities. And then isolating the surgical leg, I think that is huge. So doing single leg open chain knee extension, single leg stands, single leg squats if they can tolerate it, single leg holds in like a wall sit. And so if you're not doing single leg exercises with your patients, they really should be. We know that their surgical leg is going to be weaker, but if we give them the opportunity to use their non-surgical leg in exercise, then they will always choose that over using their surgical leg. Okay, our next patient, sorry, this is a little small, but they're 6 months post-op now. And we in rehab would still be seeing these patients. We don't have sports scientists like some of the clinics do. And so we continue with our patients throughout their entire course until they're ready to be done. Especially the patients who aren't necessarily associated with like a team. So this patient, 6 months post-op, their range of motion is 0 to 130 degrees. Before surgery, they could play tennis a couple days a week. They were hiking, they were backpacking multiple day trips. And so at this point, they've passed all their functional tests. They are significantly higher than their age-matched norms, which isn't surprising given how active they were before surgery. And they're testing better now than they did preoperatively. So we have the benefit of having tested them prior to surgery. And so we know what they were like beforehand, and we can compare them to where they're at now to where they were before. And right now their program is going to the gym regularly. They're riding the stationary bike for 30 minutes or more. And the program on their bike includes some hills, so they're getting some resistance. They're doing double leg press with 150 pounds, 3 sets of 10, and they're doing single leg knee extension at the gym. They're wondering if they're ready to return to playing tennis. And so this is where, we do functional tests for our total knees, but for those that it's appropriate, we also do the same return to sport testing that we would do for our ACL patients. Our surgeons, and I think in the United States, it's trending more toward being okay with patients returning to higher level activities like running, maybe basketball, tennis, as long as the patients kind of understand the risk. They know that they may be putting their joint under some risk, but if they can demonstrate the strength that they need to return to these sports, then the surgeons are kind of becoming more okay with that type of activity level. I don't know what the trend is like here, but I feel like a lot of changes happen both in the technology of total joint replacement and in how we rehab people, and in the activity level of patient population. And so for, the patients who want to get back to this type of activity, we tell them what their risks might be, but if they decide that that's important to them, we help them with that. So this patient, we decide to do some return to sport testing. So do Y balance test, we'll do the Biodex test, and handheld dynamometry. Okay, so we tested our patient. Y balance test, they were able to reach 10 centimeters anteriorly on their surgical leg, 22 centimeters posterior medially, and 20 centimeters posterior laterally. On their non-surgical leg, 15 centimeters anteriorly, 23 centimeters posterior medially, and then 22 posterior laterally. So down here are the percent differences. Anteriorly, they were 40% less able to reach less far on their surgical leg than their non-surgical leg. Posterior medial was 4% and posterior lateral was 9.5%. So posterior medial and posterior lateral were pretty good. But anterior, that tells us we've got some work to do. So giving this patient single limb stance exercise might help them improve their balance, but it's not going to help them get better at the anterior portion of the Y balance test. They're going to need to practice bending their knee against gravity in a standing position. So lunges, sliders, those deep step downs and step ups are the types of exercises that are going to help that patient get back to that type of activity. Okay, and then in addition to the Y balance test, we did a Biodex test. Their quad was had 20% deficit on the surgical side, and their hamstring was a 5% deficit. So we feel pretty good about their hamstring. Quad, in our post-op return to sport, they might be ready to start doing a little bit of running if that's what they want to do, but they're not yet ready for return to sport, playing basketball, that kind of stuff. And then handheld dynamometry, we did 24.9 kilograms at the quad and 18.1 kilograms at their hamstring on their surgical side, 34 kilograms on their non-surgical side for quad, and 19.1 for hamstrings. And so their quadricep, at least in this test, this is also just, an example, 30.8% deficit into extension on their surgical side. And again, hamstring was around what we found on the biodex. And so clearly this person needs some quadricep strengthening. They've been doing isolated quad strengthening, but maybe not to the amount that they need to be to improve this deficit. So this is where I think starting to apply the strengthening principles that we all know become important. They're 6 months post-op. We feel pretty comfortable now that they're ready to really progressively strengthen. And so what we would recommend then is doing 60 to 80% of their 1 rep max on that knee extension machine. So they should be doing 33 to 44 pounds for knee extension, depending on if you go off of their biodex or their or their handheld dynamometry test. So we would show them in clinic what that feels like on our machine, and then we would ask them to replicate that at the gym on the machine that they have. And if sometimes the pounds or kilograms that we would recommend somebody to do doesn't exactly work for them, then it's about rate of perceived exertion. They shouldn't be able to do more than about 6 repetitions. If they can do more than 6, and if they can get up to close to 10, then it's probably too easy. They need to be working harder for fewer repetitions to really make that adaptation with this muscle. And if the hamstring were the weak muscle, then we would recommend they do something similar for on hamstring curls or some other way to work the hamstring. So rate of perceived exertion is another great opportunity. Today, in seeing the clinic, whom was showing us the machines that they have access to, and to be able to test isometric strength and then have the machine set for you what the rate of, or what the amount they should be working at for the desired goal, strengthening endurance, is so cool. It was really great to see that machine. I would love to have something like that. But right now, we have to test in a different setting and then kind of hope that the amount that we're calculating works on the machine that we have. And so it didn't sound like they have that opportunity for the leg extension, but that would be a really great addition to the rehab gyms. I'd never seen machines that will do that for you before, and I just think that is so cool. So I'm taking that home with me. Thank you. Okay, so can this patient start agility drills? Well, technically they did pass the test with the criteria that we would recommend. So they're within 25% in quads and hamstrings. And so, yeah, they probably can start doing some agility drills, some light tennis practice, following the idea of soreness rules. So if they're really sore after starting these new activities, then they may have to scale it back. If they have some soreness, but it improves with a warm up afterward, then they're okay to stay at that same level. And if they start the drills and they're tolerating it well, they've been able to do them for a little while, they don't have any soreness, no swelling, then we can advance them to the next level. Okay, we kind of talked through this already, but they didn't pass the Y balance test. Why? They didn't pass the Y balance test, not because they weren't capable of balancing. We know they can balance because they did well on the other directions. They didn't pass the Y balance test because they were struggling to control knee flexion and ankle dorsiflexion at the same time, especially in an anterior direction, which I think is always a little bit harder for the knee, especially when you have quadriceps involved. And so, as we talked about it before, what exercise would be most appropriate? We want them to pass the test and we want them to get stronger in that direction. And so giving them things like lunges and lateral step downs and high step ups would be perfect to help them get back to the things that they want to do and to pass the test. It's not just about passing the test, it's about being able to excel at being a tennis player or a basketball player, and you need to be able to bend your knee against your body weight and while you're responding to something external happening at the same time. Okay, so of course, we're not separating these things, while you're strengthening quad, you're also strengthening hip. But if we know that the patient has some hip weakness, we're gonna start them basic and determine then what the need is by testing. So clamshells, sideline hip abduction and adduction, standing hip abduction, sidestepping with the band on and a variety of different positions at the knee, down at the foot, depending on what it is you're trying to target, bridges, getting them weight bearing and controlling their hip against their body weight and against resistance. And then backward walking, lunges, deadlifts, side planks, adding resistance to all these exercises are great ways to advance. I think too many people aren't very good at controlling their hip in, this is in weight bearing on your side. And I find this to be a really great exercise for patients to get better at using their glute med to control themselves, control their hip against gravity. Okay, so hip strengthening, how do we know when to progress, if they're making progress? What information do you use to know what exercise to give or how hard it should be? And I think a lot of it is what's the patient telling you? Like I can do 30 of those clamshells in a row. Like, okay, that's far too easy at this point. We are ready to progress, whether that's progressing the exercise, adding a band and making it harder that way, we're just moving on to something more challenging. And then using tests to help us determine what muscles are most weak and how do they compare. So manual muscle testing is, the most basic way of doing that. And then handheld dynamometry is becoming more and more useful in these situations. So to test hip abduction strength, this is just an example, have the patient sideline with the handheld dynamometer here, pushing upward into the dynamometer to determine what strength do they have at their hip, doing that on both sides. And then we have comparative data. So we know for females and males between 50 and 59, and we have a variety of different age ranges that we can compare our patients to depending on how old they are. I think I said when the cohort was here at OHSU that I would share this information, and I haven't done that yet, but we can make sure that everybody has access to these normative values if you don't have them, because it's helpful to be able to show patients like, oh, well, most patients your age can push 44.2 pounds into this dynamometer in this position, and you only did 20. And so clearly we need to do some strengthening to get you up to what we would consider normal, particularly if you're wanting to do activities that require a large strength in that muscle group. Okay, so then moving on to gait training exercises. Again, we're starting this early and then advancing it along as the patients come along, but starting with weight shifting side to side, forward and backward, learning terminal knee extension and standing. I like these stepping over cone drills as patients with total knees are kind of figuring out how to bend their knee as they're walking. Having patients practice stepping over things, practice bending their knee in this position helps them learn that knee flexion through the swing phase of gait. And then advancing that to functional strengthening. What's important to the patient and what's important for them to function well. I think both of those things have to be considered. So the patient, lives in an apartment where they have to be able to go up 3 flights of stairs. Okay, we need to practice that. And we know that this patient has a high fall risk, and so we need to give them some single limb stance activities or other balance training activities, even if they don't tell you that that's important to them. So I think a blend of what are the patient's goals and what do we know patients need to be able to function well. Most patients don't have a goal of getting their hips stronger, but we all know that they need that to protect their knee and to function well in life. And then helping them be able to learn how to get off of the floor. How can they use their quad strength and glute strength to be able to get them off the floor, especially if they are a high fall risk. We want to make sure that patients can recover if they do happen to fall. Okay, so main takeaways. Hopefully we all are on the same page. We start basic and we progress the patient as they're able. We want to challenge everybody's strength before surgery and afterward if we can. Take regular measures to show the patient how they're progressing and where they can improve, and then prescribe exercise based on those impairments that you're finding. And then pick exercises that are important to the patient and to keep them motivated. You want to get to basketball, incorporate a basketball into your routine as you're able to. And then use data to help you determine what the right amount of exercise is for each patient. Okay, thank you.